So I'm Nick Shammas. I'm the president and research director of the Midwest Cardiovascular Research Foundation, and I'm also an interventional cardiologist by training. So the Jet Ranger study evaluated the Jetstream Atherectomy device. It's a rotational and aspiration device as a vessel prepping device prior to drug-coated balloon versus just drug-coated balloon alone. The idea is to demonstrate, whether there's any added value for vessel prepping using the Jetstream device on top of the drug-coated balloons that have been, of course, proven to be quite effective. Yeah, so the primary endpoint of the study is looking at target lesion revascularization. But again, as we all know, that vessel prepping works best in complex lesions. The inclusion criteria have included patients typically that had longer lesions over 10 centimeter, or chronic total occlusion, or patients at least with moderate calcification and higher. So we've selected those patients on purpose, or made the inclusion criteria to include those more complex lesions, so we can get the best benefit, out of the Jetstream vessel prepping. This was a randomized trial, 2-to-1 randomization with Jetstream plus drug-coated balloon versus drug-coated balloon alone. And the drug-coated balloons selected were the Ranger balloon as well as the Impact balloon. So initially, it was designed as a superiority study to include a larger number of patients, of about 255 patients or so, in 11 sites, in the U.S. And in fact, the 11 sites did enroll patients, all of them, in that particular study. However, and unfortunately, the study had to be stopped earlier just because of poor enrollment due to two reasons. Number one, the warning about the drug-coated balloon and the increase in mortality at 5 years. And the second one is the COVID pandemic, that affected enrollment in multiple sites. So we actually ended up enrolling a smaller, number of patients. And I do believe we can qualify the results in that case as more exploratory, considering the less enrollment anticipated. The primary endpoint of the study is looking at target lesion revascularization at 1 year. The follow-up will go on all the way to 3 years, but the primary endpoint is at 1 year. And the target lesion revascularization, as an intention to treat analysis, was defined as repeating the treatment in the same zone that has been previously treated. But this time we've included, stenting as a failure. In other words, stenting happening during the procedure is considered a target lesion revascularization. That was a primary endpoint. The secondary endpoint did not include that. That means target lesion revascularization start to be counted post-index procedure or post-discharge. But looking at the primary endpoint, the study showed a significant reduction in bailout stenting, which led actually to a statistically significant less target lesion revascularization, in the Jetstream atherectomy arm compared to the DCB arm alone. And in fact, the freedom from target lesion revascularization at 1 year was 100%, and that's 11 sites enrolling, in the Jetstream plus DCB versus less than 50%, freedom from TLR in the PTA arm. And that's mostly accounted for by the fact that bailout stenting was very high, in the PTA arm alone, or the DCB arm alone. About 50% of those patients required stenting. Remember, these are complex lesions, and that high bailout stenting is not a surprise. Well, Jetstream atherectomy clearly is a powerful vessel prepping device that leads to less stenting, and we've demonstrated that very clearly in this study. And I believe that supports previous data, and this time in a more randomized fashion, in multi-center trial. And that is an important finding for the strategy of leaving the least behind. So using that device, particularly in zones, where you do not want to see a stent, like, the common femoral artery or the distal SFA or the popliteal arteries, this would be an excellent device to use with very, very good outcome. And you do not have to really use a stent in that regard, as long as you combine that device with the drug-coated balloon. Specifically here in this trial, it was either the Ranger or the Impact balloon. Well, we would like to see a larger, randomized trial to confirm, this data. And I think it may very well, considering how excellent the early data with the Jetstream and DCB, maybe something looking at potentially comparing some of that data to primary stenting with a drug-eluting stent. I think these are two different strategies, but I believe the data that we have seen in this particular trial may very well create a very strong competitor to the primary drug-eluting stenting and offer a new strategy for patients where you leave the least amount of metal behind.